Hello and welcome to Chapter 2 in Electronic Health Records. We are going to be starting on page 29 and 30. We're going to slide through the learning objectives, but we're going to be talking about the content of the health record. So we're going to start out with a little bit of history, and you can see an EHR timeline on pages 28 and 29, and then over into the text on page 30. Okay, so on page 30, we're going to start right there in the middle. The concept of electronic health records has emerged from the growing partnership between healthcare and technology. The integration of EHRs in the healthcare practice is built on the foundation of health record content. Health records contain essential elements of clinical, administrative, financial, and legal information that play key roles in a patient's current and future healthcare. So over on page 31, Hippocrates, considered one of the most important figures in medical history, and his followers were among the first to describe and document many diseases and medical conditions. However, Chun Ya, a famous Chinese physician of the Han Dynasty, who died around 8 CE, kept the first known health record. He tracked his patients' names, residences, occupations, disease information, diagnoses, and prognosis. This record provides valuable historic data. Then between the 1790s and the 1821, some of America's earliest hospitals began keeping patient records. These facilities included New York Hospital, Pennsylvania Hospital, and Massachusetts General Hospital. Health records, historically restricted by the documentation habits of each individual healthcare provider, began to evolve in the United States during the Civil War. During this time, doctors began to record medical information in an increasingly standardized format, as a social and physical mobility meant that they might treat patients they had never seen before. This trend continued as health records were established for immigrants to America at the advent of the 20th century. In 1917, the American College of Surgeons developed a hospital standardization program that established the minimum standards, which identify the elements required for reporting care and treatment. Minimum standards ensured that the health record communicated an accurate account of the healthcare information as well as the status of the patient. All right, we're going to continue on down through in the evolution of the electronic health records. Starting in the 1950s, microfilm was used, and it became a popular storage option for long-term retention of health records. And then down in the 1970s, you see that Dr. Lawrence L. Weed, he was considered to be one of the pioneers in the EHR movement. Dr. Weed, along with his colleague Jan Schultz, developed the problem-oriented medical record, a systematic approach to the documentation of medical records. In the 1970s, they also developed a software program called PROMIS, or Problem-Oriented Medical Information System, at the University of Vermont under a federal grant. Healthcare providers did not embrace PROMIS, primarily because too much information was needed to complete the required fields, so physicians felt that they were spending too much time focusing on documentation, not enough time on patient care. In the 1990s, the U.S. Department of Veterans Affairs developed the first EHR that was used on a large scale, and it was called VISTA. VISTA is still in use today at hundreds of VA medical centers and outpatient clinics across the U.S. VISTA software is available to any healthcare provider, individual, or organization at no cost through the public domain. In 1991, the Health and Medicine Division of the National Academies of Science, Engineering, and Medicine, formerly the Institute of Medicine, issued a report calling for the elimination of paper patient records within 10 years. In the report, it noted that implementing an EHR infrastructure for healthcare was imperative to improving the quality of care in the U.S. by making patient health information readily available to healthcare providers. Then, in May of 2003, the Health and Medicine Division provided guidance to the Department of Health and Human Services on the key capabilities of an EHR system. The HMD stated that an EHR system would include the following, or should include the following. Number 1, a longitudinal record, which we talked about in Chapter 1. Immediate electronic access to patient data, accessible by only authorized users. a clinical decision support component to enhance the quality, safety, and efficiency of patient care, and support for efficient processes in the delivery of healthcare. Now, to achieve these four key capabilities of the EHR system, the HMD further recommended that all EHR systems should have the following 8 core functionalities. First, health information and data, clinical results management, order entry and management, decision support, electronic communication and connectivity, patient support, administrative processes, and reporting and population health management. All right, moving over to page 33, continuing on our timeline here. So we've talked about ARA of 2009, and it outlined federal incentives for adopting EHRs. Again, we're talking about meaningful use through HITECH. Well, without the requirements and incentives of ARA and the HITECH Act, providers may not have implemented EHRs because, again, there were lots of different barriers to those. Without that push, we may not have as many EHRs as we have today. So today, healthcare providers focus on documenting both the patient's past and present care. The health record is an essential part of a patient's health care because it helps the provider make an informed treatment decision and is a tool for communication among caregivers. All right, so let's get into the purposes of the health record. So this should be a review. We've talked about this before. So the health record is an accumulation of information about a patient's past and present health. The primary purpose of the health record, whether it's recorded electronically or on paper, is to document the health history of the patient. The health record is composed of data, which includes the descriptive and numeric attributes of one or more variables. Data collected and analyzed becomes information, and a record is a collection, usually in writing, of an account or an occurrence. All right, so moving over to 34. Let's get back into these uses. So there's 5 primary uses of an EHR system. As discussed previously, delivery and the management of patient care are arguably the most important primary uses. Next, we have financial processes such as billing and reimbursement, administrative process such as quality improvement and legal documentation, and patient self-management such as the personal health record and the patient portal. There are 4 secondary uses of the EHR system. These include education, regulation, research, and public health. All right, so let's talk about these different types of health record data. You can see the image here. With the health record, you have those 4 different types: clinical, administrative, legal, and financial. And those are all going into the health record. So let's talk about each one of those individually. Okay, so first we have our administrative data on page 34. This data is information that the patient provides or populates in the health record. The administrative information typically found in the health record includes the following: the patient's name, their address, telephone number, their place of birth, the date of birth, their age, sex, marital status, ethnic origin, and their emergency contact information. The healthcare staff collects administrative information to verify the patient's identity and to help create a patient's demographic profile. Moving over to page 37, we're going to get into clinical data. Clinical data includes the medical information taken and recorded by the healthcare provider. The clinical data should be detailed, complete, precise, timely, and accurate because the information plays a large role in the overall health plan of the patient. The clinical data includes documentation such as the following: you have your pathology and laboratory reports, history and physical assessments, allergies, x-rays, list of medications, surgeries, hospital admissions, and progress notes. All right, moving on to legal data. Legal data in the health record may be found on a variety of forms that are also considered legal documents. These documents include the following: release of records. These are written requests to release patients' health information to another healthcare provider or another entity in need of the patient's information. Then you have your HIPAA forms. These are your notice of privacy authorizations. Then you have general consent for care. It's an agreement to general treatment and care. And then you have your informed consents, which is agreement to a procedure. You also have advance directives. These are the written statements describing a patient's wishes regarding medical treatment in the event that the individual is no longer able to make such decisions because of illness or incapacity. Health records are considered legal documents. A court of law may use health record in many different types of legal proceedings. The healthcare facility protects itself by requiring proper documentation and ensuring accurate information where and whenever it is required. All right, and last but not least, moving on to financial data over on page 37. Financial data consists of insurance and employer information. A copy of the patient's insurance coverage, when available, may also be included. There may be times when a patient pays for healthcare services with a payment plan or another type of financial arrangement. The financial data section of the health record would note this agreement. Financial data is often combined with the administrative data, meaning that both types of data are collected on the same form. All right, moving over to page 39, we're going to talk about some core data elements here. So in 1996, the National Committee on Vital and Health Statistics completed a review of core health data elements and developed a list and definitions of the 42 core elements that can be used in a variety of healthcare settings. The patient provides the patient enrollment data at the initial visit with the healthcare provider or facility, not at subsequent visits. And if you flip over to page 40, Table 2.1 lists the core data elements and their definitions. And so you got a few pages of there that you can just kind of look through. So in addition to the core data elements proposed by the NCVHS, other data sets have been proposed as national guidelines to encourage the exchange of information across healthcare providers and settings. The American Health Information Management Association developed a core data set for the physician practice EHR, with its core elements divided into demographic and administrative information, vital signs, reason for visit, present illness, medical history, physical examination, problem and medication list, screenings, immunization, summary, referrals, and authentication. All right, so we're going to skip through page 40 through 42, and we're going to pick up with the health record formats, which should be also a review, over on page 43. So the format is related to the arrangement of a paper health record. There are no specific requirements on how paper records are formatted as long as the organization uses the same format throughout its facility. And there's 3 organizational formats used in paper health records. Our first one we're going to talk about is the source-oriented record. Now, the source-oriented record is the most common format used by healthcare facilities. This format organizes the health documents into sections that contain information collected from a specific department or type of service. For example, all progress notes, laboratory reports, and radiology reports are assembled together in their respective sections. Within each section, the health record content is organized in chronologic order. SORs permit rapid retrieval of health content, although the format can make it challenging to view the complete health status of the patient, because again, you're having to go to each section to see the most recent information. You have to go to the physician section to see the most recent progress notes, or you have to go to the lab section to see the most recent lab results. You have to go to the radiology section to see the most recent radiology report. So it is kind of separated out, but it does allow for rapid retrieval. All right, our next type is the integrated health record. The second format is the integrated health record, which is organized either in chronologic or reverse chronologic order. The health content is not separated by department or type of service, therefore health documentation is viewed by date. Healthcare facilities may use the integrated health record format in several ways. The medical chart may place all forms together or be organized by healthcare setting. The integrated health record provides a complete view of the health status of the patient, although this format makes it difficult to compare findings from the same type of service, such as comparing 2 radiology reports completed at the beginning and the end of a patient's stay. All right, and our last is the problem-oriented record. So as we talked earlier about Dr. Lawrence L. Weed, he developed this type of record because the The source-oriented did not provide a complete view of the patient's health status, but the problem-oriented focuses on the assessment of the clinical documentation by healthcare providers and the creation of a plan that addresses the patient's health concerns. This type of format promotes a team approach to documentation through the use of a SOAP format progress note. Now, a SOAP note is going to be further clarified by the following. So, S stands for subjective. This is per the patient or their representative. It's their reason for seeking care, and it can include the chief complaint, the symptoms, and a history of illness. Then we have objective, O. The provider notes such as physical findings, their clinical signs observed, and they can document the results of tests. Then we have assessment, A. Provider opinion on the condition or diagnosis informed by the subjective and objective elements. And then we have our plan. This is the healthcare provider's the healthcare provider's plan to diagnose or treat the patient. And you can use this SOAP format in both paper and electronic records. All right, so we're going to move along over here to the health record content over on page 45. So the content of a health record will vary depending on the type of healthcare facility. When we get to chapter 4, we're going to go into greater detail on the different types of healthcare facilities. But in this chapter, we're going to talk about patients in the acute and ambulatory settings. Now, we're going to start with the acute care setting. Facilities that provide acute care include acute care hospitals and long-term care hospitals. Patients who are admitted to these facilities are called inpatients. Inpatients occupy a hospital bed for at least one night in the course of treatment, examination, or observation. For an inpatient admitted to an acute care setting, a health record usually contains the following content. We have an admission record, which is a state of the patient when he or she is admitted to the acute care facility. We have the history and physical. This is information regarding the patient's past and current health condition, assessment, and treatment or diagnostic workup plan. We have progress notes. These are entries of the patient's care and progress reported by the healthcare providers. We have lab tests. These are tests and laboratory results ordered by the healthcare providers. We have other diagnostic tests, medical tests that assist in the diagnosis of the patient's health issue. We have operative notes for those patients that are having surgeries. These are notes immediately written after surgery that document the procedure and the results. We have pathology reports. These are detailed information on the review of specimens from tissue or cell biopsy. Then we have physician orders. These are orders given by physicians for medications, fluids, patient testing, and etc. Then we have our consents. This is all of our authorization for treatment. Then we have consultations. These are reports provided by other healthcare providers that review the patient's health issues. Then we have our emergency department encounters. This is going to include documentation of visits or encounters in the emergency department. Then we have discharge summaries. These are summaries of the patient's course of care signed by the attending physician. The content in each record may be supplied in different formats, but typically contains similar data. All right, moving over into ambulatory record content. Ambulatory care is an increasingly popular mode of healthcare delivery. And then we have a list here of some of the different ambulatory care settings. This is going to be your physician offices, clinics, surgery centers, dental offices, imaging centers, occupational health centers, oral and maxillofacial offices, podiatrist offices, pain management, community or college health centers, and your urgent care centers. So we know that the term ambulatory means outpatient. So in ambulatory settings, our patients are outpatients. Outpatients are patients who do not spend more than 24 hours in a healthcare facility and or are not admitted to the hospital. Let's talk about the ambulatory care record content. Each facility, unless part of an organization, creates and maintains its own health record from a patient. The ambulatory care record typically contains the following content: demographic information, including the patient's name, address, date of birth, and other patient information not medical in nature. Contact information. This will include various telephone numbers and email addresses, as well as their emergency contacts. The history and physical, which is the health history, a review of vital signs, and a complete organ-specific physical exam. Then we have immunization records, which will be a comprehensive list of dates and types of vaccines received as a child, as well as additional vaccines such as flu, tetanus, and hepatitis. We have problem list. These are lists of patients' current health issues. Then you have allergy list. These are lists of medications, food, and other items to which a patient is allergic. Prescription list. These are the list of current medications, including the dosages. Then we have progress notes. These are updates to the patient's healthcare issues, and they may be in a SOAP format. Then we have an assessment summary. This is a summary of the likely causes of the patient's current health issues and provides a course of action to address the health issues. We have consultations, which again is documentation of a patient's visit to another healthcare provider and what that healthcare provider recommends or concludes. Then we have referrals. This is permission or suggestion for the patient to be seen by another healthcare provider. We have treatment plans. These are plans of treatment for the patient's health issues. Patient instructions. These are the directions and orders to be followed by the patient to help with his or her health issues. Laboratory tests and results. So again, test and lab results ordered by another healthcare provider or by the healthcare provider. Again, consents. This is the patient's authorization for treatment. We have communication. Could have letters, emails, telephone messages, or any other documented communication. External correspondence. This is going to include communication between the healthcare provider and any other provider or carrier that provides information about the patient. And last but not least, we have financial information. These are the payment arrangements and the insurance information. Each specialty practice may provide the health information in a slightly different way, but again, the concept and purpose of each category is the same. All right, moving on to the documentation in the health record. The healthcare facility is responsible for the quality of care provided to its patients. Direct documentation of this care must be provided in a paper record or EHR system and is the responsibility of the healthcare provider. This documentation must be acute, timely, and complete, reflecting all procedures, treatments, medications, tests, assessments, observations, and communications involved with the patient care. Remember, if it's not documented, it didn't happen. The maintenance and accuracy of the health record are important responsibilities of health information staff, whose duty is to ensure that healthcare records are readily available when patients arrive for care. The staff must also ensure that all forms are in each patient's record, verify that the healthcare provider has documented care, validate the accuracy of the coding of service, and adhere to established healthcare data standards. All right, so let's move on to our documentation guidelines. Every healthcare organization should establish policies and procedures specifying health record documentation guidelines for both paper and electronic health records to ensure that health record documentation is accurate, timely, and supportive of assessment, diagnosis, and treatment. These documentation guidelines are established based on the laws, rules, and standards of licensing agencies, accrediting bodies, and payers of healthcare treatment and service. Some of the typical documentation guidelines for paper and electronic records can be found in Table 2.2 on page 48. So you get a little bit more detail than what's in this slide. So well, actually it does include all of it. So you can see that over these two tables in the slides, or you can just look at it in the one table on page 48. I'm not going to read through that, but it does give you your guidelines for your paper health records on the left column and your electronic health records on the right column. All right, so within the documentation guidelines, there's going to be 3 areas of concern that affect patient safety. First is the legibility of the handwritten entries. Second, the use of only approved abbreviations and acronyms in the documentation. And 3, the protocol for changing or correcting documented entries. So let's talk about each one of these individually. All right, so the legibility of entries. When working with paper record entries, interpreting the handwriting of healthcare providers may be difficult. Consequently, healthcare personnel must query the appropriate staff members about any unclear entries. This verification protects both the safety of the patient and the liability of the healthcare worker and the facility. And you can see another example of that handwriting in figure 2.7 over on page 49. I can't read it. You'll have to let me know if you can. All right, and our second one was those abbreviations and acronyms. So, abbreviations and acronyms are often used in the health record. Therefore, to ensure clear communication, there are standards for abbreviations and symbols that should be followed when documenting information. Some examples of approved abbreviations are provided in Table 2.3. That's going to be over on page 50. Healthcare facilities can place additional rules in their bylaws that indicate other acceptable abbreviations per facility preference. The Joint Commission developed an official do not use list of abbreviations as part of its information management standards that healthcare organizations must follow. In addition, the Commission has proposed a list for possible future inclusion in the official do not use list. And you can see the do not use list in figure 2.8, also on page 50. All right, moving on to our last was changing or correcting documentation entries. We discussed this in health records and we discussed this in law. So this again is going to be a refresher for you. So if we're on page 51, healthcare personnel need to follow established procedures when changing or correcting documented entries in the paper health record. Information must not be erased. When correcting information in an EHR, authors strike through the documentation in error and include the date and author initials, or they move the documentation to a separate, retrievable electronic file. Information or documentation is never completely deleted from the EHR. Healthcare personnel may also document an addendum to clarify documentation. Information may not be deleted from an entry. So remember, you're not deleting or obliterating information to where it can't be read. It must remain there in that record. All right, so let's move on to our healthcare standards, continuing on page 51. Several accreditation, professional, and federal organizations provide guidelines and support on maintaining the integrity of patient health records. By affiliation with these organizations and meeting their professional standards and goals, healthcare facilities can distinguish their services from others as well as reduce the number of state and federal reviews. The focus of all of these organizations is to improve the quality of patient care and health record documentation. Now, I'm not going to read through each one of these, but our accrediting organization examples listed in your slides is going to include the Joint Commission, National Committee on Quality Assurance, which is NCQA, the Community Health Accreditation Program, the Accreditation Association for Ambulatory Healthcare, and the Commission for Accreditation of Rehab Facilities, CARF. So be sure to read through that section to know what each one of these different organizations does, because they don't all, accredit all of the organizations. So they do have their certain focuses. All right, moving over to our professional organizations. You see AHIMA is one, and then you have the Association for Healthcare Documentation and Integrity, and then we've talked about HIMSS, the Health Information and Management Systems Society. So be sure to read through your professional organization section as well. And then we're going to move on to our federal organizations. So federal organizations that are actively involved in setting standards are going to be AHRQ, or the Agency for Healthcare Research and Quality, CMS, the Health Resource and Services Administration, and the QIOs, your Quality Improvement Organizations. So again, read through your federal organization section as well. All right, moving on over to ownership and stewardship of health records and health information. We're at the bottom of page 52. Health record and health information ownership and stewardship are controversial topics that have grown increasingly complex as healthcare facilities transition from paper records to EHRs. Historically, state laws and healthcare professional associations have accepted that the healthcare facility that created the health record owns the physical health record. For example, a sole practitioner, which is a single, independent healthcare practice, owns the record created in his or her practice, just as a hospital or other inpatient facility owns records for all patients admitted to or treated at their facility. Historically, there have also been discussions and attempts to separate the ownership of the physical health record from the ownership of the health data contained in the record. Is the patient the owner because he or she is the subject of the record? Or is the healthcare facility the owner because it generated the information and physically has possession of the record? Many leaders in health information management anticipate that future legislation will address the subject of ownership of health information, ultimately creating a uniform definition of ownership. All right, moving down to ownership versus stewardship. This again should be a review. We did discover this, or we went over this in law for sure. So while clarification of the ownership of health records and health information is needed, the concept of stewardship is a way to address the responsibilities of retention, privacy, and maintenance of health records and health data without having to solve the issue of ownership. Since stewardship implies careful and responsible management as stewards, all healthcare providers and staff involved in the creation, use, maintenance, and retention of health records and data are responsible for ensuring that health data is generated, used, and stored in a manner that complies with all the required laws, rules, standards, and guidelines. Now, patients have rights to access their records, and so whether it's on paper or electronic, they can go request that copy from their healthcare provider. Typically, they're going to provide a written request, sign a HIPAA-compliant release of records form, and then they're going to pay their necessary fees. Now that records are housed in the EHR system, an increasing number of patients request an electronic copy of their records. Now we'll be talking about that a little bit more in Chapter 6. Alright, so let's talk about the importance of the transition to the EHR. Unfortunately, it took a natural disaster to underscore the importance of transitioning from paper health records to EHRs. On Monday, August 29, 2005, Hurricane Katrina made landfall in southeastern Louisiana. The impact of the hurricane caused the levee system in New Orleans to fail, and many parts of the city flooded significantly as a consequence. This disaster washed away thousands of paper records, and many residents of the greater New Orleans area lost all of their medical information. In addition, many healthcare providers fled New Orleans, which left many patients adrift in their healthcare needs. These patients had no records of their health histories, current health status, or information regarding their medications, and had no way to contact their healthcare providers. In response, the federal government, along with public and private organizations, created the katrinahealth.org website to help healthcare providers and pharmacies obtain access to patients' prescription information. Although this service helped many New Orleans residents, one segment of the city's population still had access to their records. Guess who that was? That was the veterans, because of the VISTA system. Because this information was electronic, displaced veterans were able to access their records no matter where they chose to locate. Hurricane Katrina highlighted the necessity for health information to withstand natural disasters, an important lesson that supports the initiative for the development of EHRs. Now, let's talk about the conversion. So in our picture here, and the picture in your book, we have St. John's Hospital in Joplin, Missouri. And I don't know if any of you remember this, but back in 2011, a tornado came through and pretty much ripped that hospital to shreds. Now, one thing about that hospital was they had already started their transition to electronic health records. So they, if you read the Consider This on page 55, they got hit with the tornado 3 weeks after they made their move from paper to electronic. So they were able to recover patient information and send it to other healthcare facilities. So that's an interesting little section to read. So be sure to read that about the St. John's Hospital in Joplin, Missouri on page 55. All right, so what are our limitations of paper records? Paper health records have served an important role in patient healthcare for many decades. However, they also present many challenges to healthcare providers, including the following: increased complexity of healthcare delivery, single location of records, restricted access allowing only one user to view records at a time, inconsistent documentation, and unsecured storage in the event of a natural disaster or human error. In addition, the paper health record is time-consuming and labor-intensive. If you take a look at figure 2.10 on page 56, it shows the paper record workflow. So due to the challenges presented by this time-consuming workflow and the increasing amount of patient and provider information required to be documented, the concept of using an EHR system became increasingly embraced by healthcare practitioners. So let's get into the advantages of the EHR. So we talked about in chapter 1 that an EHR is not just an electronic version of a paper record, although they have common data elements. Rather, an EHR begins with a database populated with health content from the patient's healthcare encounters. It includes demographic information, progress notes, assessments, results, consultations, and many of the other documents found in the paper health record. The database of the patient's healthcare encounters is updated each time the patient seeks medical care. Healthcare providers can enter information in an EHR using laptops, desktop computers located in patient examination rooms, or wireless devices used during patient encounters. This easy accessibility to a patient's health record is certainly a key advantage over a paper record that must be accessed from one location. The provider can log into the EHR using a unique username and a secure password. Once the record is accessed by the provider, his or her activities within the record are tracked by the system. What is that called? My favorite word, that's metadata. The record itself offers a standardized format containing drop-down menus, lists, icons, and free text areas for practitioners to enter health information into the database. Because of this standardization, EHRs can be easily searched for specific patient information, as well as automatically prompt clinicians to send reminders and follow up with patients. Lastly, the electronic data format provides users with a complete picture of a patient's overall health status. Now, challenges of the EHR transition. So implementing the EHR system does present some challenges. Converting the paper records into electronic format is both time-consuming and costly. And so healthcare's delivery systems convert paper to an electronic format. Portions of the patient's record will be stored electronically and on paper, which results in our hybrid record. Healthcare providers with a small patient population are likely to be able to convert to EHRs in a shorter time frame than healthcare providers with large patient populations, such as your major hospitals. For these larger facilities, the conversion may take several years, and consequently, hybrid health records will need to be implemented. There may be additional challenges in converting from paper health records to EHRs, such as dealing with duplicate records, establishing the identities of patients and unique patient identifiers, detecting insurance fraud, and identifying questionable identities of patients and various components of the EHR system. Once all the records have been converted, healthcare workers must review records to ensure accuracy. Even with EHRs, there is room for error during the data entry or data conversion process. Removing erroneous information from an EHR is not allowed, and doing so may be seen as fraud if it is attempted. Training all users of the EHR system to use EHR content can be difficult. Employees may lack the necessary technological skills, and some users may be reluctant to learn a new system. The goal of an EHR system is to improve patient healthcare by allowing access to multiple providers across all aspects of healthcare and involving the patient more directly so that all players have current information and the patient's past and present health status. Having accurate and accessible EHRs will result in improved patient care and outcomes. Alright, so let's look at our last slide here. This is our chapter summary. So be sure to read the full chapter summary. This is just going to hit the highlights. So the purpose again of the health record is to document the health history of patients. Administrative, clinical, financial, and legal details comprise the types of data within health records. Data elements are largely informed by the National Committee on Vital and Health Statistics. The record may be formatted in ways such as source-oriented record, integrated health record, or problem-oriented health record. And a variety of accreditation, professional, and federal organizations influence the health record standards and provide industry support. The ownership of the record itself versus the information therein is a continued area of focus. And health record and health information ownership is a controversial topic. Healthcare providers and staff are considered stewards and must use and store health data in compliance with laws, rules, standards, and guidelines. So again, be sure to read this entire chapter. Again, I did not cover every single word. So again, read through that chapter summary. And again, you're going to answer your, check your understanding questions in Course Navigator. And again, if you want to start keeping a running list of all the different acronyms and initialisms that are at the end of each chapter, just so you're familiar with all of these, might be a good thing to do. So good luck and happy reading.